needs really no introduction in the area of acetabular fractures, has an incredible history in terms of clinical and research experience with acetabular fractures. Joel Matta from the Hip and Pelvis Institute at St. John's Hospital in Santa Monica. Joel?
Thanks, Phil. I'll go ahead with, I was asked by you, and I'm happy to present the results. I'm going to talk about my results since I have now I think the largest series available. We happily just had it accepted to JBJS, and it's a 20-year survivorship study regarding the hip and treatment of acetabular fractures.
I'm sorry to interrupt you. This is Roman. Would you mind just starting your webcam, please, so we can see you?
Oh, okay. I think I missed the start sharing button.
Oh, perfect. Thank you so much.
You have it now, Roman? Thanks. Okay. So I'm talking about immediate and long-term results of surgical treatment of acetabular fractures. And this is for 1980 through 2006. And what the immediate results means is how good did we do at the surgery? And that means reduction with the goal of anatomic reduction of the innominate bone as well as the joint. And the long-term results are survivorship of the joint. Did the joint continue to function to the patient's satisfaction, or did they need to go on to a total hip arthrodesis? And now it's whiskey time, the boss used to say. I'd toast the boss. I don't have a whiskey here, but later maybe. And that's Emile Letournel, who got me inspired on this subject and really created a lot of the radiology as well as surgical approaches. Emile at his first course in Paris, which shows the great innominate bone, which was, Roman, remind me again, how many minutes do I have?
You have 9 minutes left.
9 minutes, okay. So we're on a 10-minute talk. Okay, thank you. And the group of us went to Paris to learn to study with him, and after that I think a lot of the current group that's on the faculty just grew out of this contact to Paris and then spreading it through the course. As mentioned, the approach has always been a single approach using an orthopedic table. I now use the ProFX. We had the Jude before. Specialized reduction forceps and screw and plate fixation after we obtain an anatomic reduction. The results, as far as displacement, I grade anatomic within 1 millimeter, imperfect within 2 to 3 millimeters, and poor greater than 3 millimeters. But it's really the anatomic or perfect reduction that we're trying to achieve. And the clinical grading score originally that Letournel used was Daubigny-Postel. I continued to do that with a slight modification, just meaning that making the motion score a little more strict, meaning that the patient needed 95% motion. The results using this follow-up study and correlating the results with accuracy of reduction was published in JBJS in 1996, which was about 226 hips with minimum 2-year follow-up, which showed a high correlation of reduction, anatomic reduction, with the clinical results. We've just finished recently a 20-year survivorship study after fixation of acetabular fractures, and I think this will be a nice addition to the literature, both for acetabular fractures and also for implications of articular fractures in general. This was headed up by Moritz Tonest of Bern, Switzerland, who did the bulk of the work on this, and we included patients 816 acetabular fractures for analysis that had minimum 2-year follow-up or had a bad result prior to 2 years. Average follow-up's 10 years, maximum follow-up 29 years. 87 patients had died and about 1/3 had been lost for follow-up in the group. 30% simple fracture types, 70% of the associated fracture patterns, as Mark just defined in his talk. The most common fracture type in the series is both column, followed by transverse posterior wall, followed by posterior wall. So there were certainly complex fractures in this series. And here's just a distribution of simple and associated. and the distribution. You see both column, transverse posterior wall, and actually T-shaped was relatively common too at 12% in the series. Approaches, Coker-Langenbeck 43%, ilioinguinal 40%. These approaches used alone, extended 16, 2 approaches in 1% of cases, KL plus ilioinguinal. The approach over time, 1980 through 2005, I'll just point out Coker-Langenbeck the most in this cream-colored. The light blue is ilioinguinal. Extended approach use declined over time, as did 2 approaches was not used very much throughout the series. So the big majority of cases done through a single approach, either Coker or ilioinguinal. Why did the distribution of approaches change? Probably over time I learned to operate better through either the Coker or the ilioinguinal approach alone. The other factor might have been a little bit of a changing fracture population as patients have gotten older, where the average age started out about 30 and now it's probably a little over 40, the average age of the acetabular fracture patient. Reduction, anatomic in 75%. I'll go to the pie chart. Anatomic reduction a little over 76%. Imperfect in another 18%. Poor are 4% of cases, and then 2% in a surgical secondary congruence. This is with a both column in which the acetabulum might be reduced, but there is some residual deformity of the innominate bone. Reduction over time, the anatomic reduction, what we're looking for in the blue, has increased steadily and progressively over time to getting anatomic reduction. So happily, even after almost 30 years, the reductions, I still maybe get a little bit better at the reduction. And reduction with the different fracture types, probably fairly comparable across the board. Now we're getting to the meat of the study, which is really survivorship of the hip at 20 years. Overall survivorship was 79%. So 79% of the patient at 20 years survivorship still had a functioning hip. Some of these, of course, had some degree of arthritis, but not to the degree that the patient elected to get a total hip. And the survivorship for the different fracture types, you see here, both column, transverse posterior wall, and I'll go over some of the individual survivorships. So if we look at the overall survivorship curve, we see it in the dark black line, 1 standard deviation above and below. Getting out to 25 years, it's dropped a little bit from the 20-year down to about 74% at 25 years. Both column survivorship, you see with the dotted line just above the black line, so the both column is a little bit better than the overall survivorship. And then when we go to now anterior wall survivorship, this was the worst, but there was less than 10 cases in the series, but you see less than 40% survivorship. Why is this? It's mostly older patients. Marginal impaction is often present with this also, as well as femoral head impaction. Posterior wall survivorship, this has been described as a real bad player, but really you can see the dotted line is not much off the average. So if you get a very good reduction in fixation, even with the posterior wall, you can get a very good long-term survivorship. Transverse posterior wall, also identified as a bad player, but still the dotted line very close to overall survivorship. And so there is hope even with these difficult fractures. Just a few case examples. For operation through Coker-Langenbeck, the patient is prone. This is how it's done on the orthopedic table. Posterior wall, a common fracture pattern, and is survivorship at several years, a very good joint with this, even with impaction and intra-articular fragments. Ilioinguinal, again, done supine, so specific position. I don't use a floppy lateral really on any cases. This is both column with marginal impaction, anatomic reduction following, and this is a 2-year survivorship picture with a very good hip. This is the extended iliofemoral. Done, the main indication that I use it for now, done with the patient lateral on the orthopedic table, would be a fracture dislocation of the SI joint where this upper portion of the posterior column also leads to a fracture dislocation of the sacroiliac joint. So the best access for this, two approaches don't give you access. This is the indication for the extended with the anatomic reduction, also a good result. The two approaches are done in the stage fashion, prone KL followed by supine ilioinguinal, and this is a T-shaped plus posterior wall. This is another area where you can get transitional forms that can be between T-shaped and anterior wall plus posterior hemitransverse. With a T-shape from posterior wall, successive KL followed by ilioinguinal, and the result at 4 years. A number of factors were examined for prognostic value. What we found was that non-anatomical reduction correlated actually the most highly. So anatomic reduction, congruence with the roof, these were most important for a good long-term result. Femoral head cartilage lesion was important, as was older age. Involvement of the posterior wall really wasn't very significant. Initial displacement a little significant. Acetabular impaction finally not a significant factor even in this 800-some patients. Osteonecrosis can be from the injury, but really shouldn't occur more than 3%. And what many people call necrosis is actually wear of the head. This is from malreduction. This is from a screw in the joint. It's an inevitable complication, but really usually more common than the necrosis. The goal of surgery for acetabular fractures then remains preservation of a mobile and painless hip for the rest of the patient's life. Long-term follow-ups to 20 years and 30 years in the series of myself and Letronel indicating that in the majority of the cases the hip can be preserved. The surgeon challenges remained anatomic reduction, avoiding complication. Fracture tables, specialized instruments allow us to do more through the Coker-Langenbeck and ilioinguinal, and thereby we can minimize surgical trauma by limiting cases to one approach and avoiding the extended or KL whenever possible. To you, Phil.
Great, Joel. That's really helpful information. You know, we had your data before, but now having up to 20-year follow-up is really going to be helpful for us in counseling our patients. Steve, is there particular takeaways from this data that you can use in counseling patients?
Yeah, I mean, absolutely. This data has, and my hat's off to Joel for collecting this data over this period of time. So to have that experience and to take the time and effort to keep all that data is really what we base everything we do on, I think, now. So I think where it's very helpful is two ways. One is we can tell a patient what they can have if they are able to get an anatomic reduction, what they can expect. And I think, secondly, something I find very useful in talking to patients when I see them back in the after surgery is what to expect for the long term. So if you had a good reduction and the patient is doing well, if you look at how the results fall off over Joel's 20-year follow-up, they don't really fall off very much. And I know Mark Roddy, when he was with Joel, looked up those. And if at 2 years the patient had an anatomic reduction and still has no signs of arthritis, it looks like their hip will last at least 10 years, and looks like in the majority of patients it will last 20 years. So I think that's very useful in telling the patient what they can expect for the long term.
Yeah, I think that's a good point you brought up, Phil. It's just that the 2-year follow-up x-ray and exam is important, and Mark did bring that to my attention, that if we have an x-ray without arthritis, it's a good indicator for kind of a low slope decline over the next 20 years in their results.
Joel, maybe I missed it, but in terms of the longer-term outcome, have you broken that down into, say, greater than 65 or 60 years of age and looked individually at that subset of patients?
We actually just drew a line at 40 years, above and below 40 years. So we're all
Yep.
getting, and there was, if you do that, there is a difference in the results. It correlates as you get older. And probably one of the main factors is that oftentimes the reduction isn't quite as good in the older patient. They're more likely to have impaction, or you may have more difficulty with osteoporotic bone. But it seems that an anatomic reduction that remains anatomic, you don't lose fixation, also has a very good has a good prognosis in the older patient. But it would be good to look at the statistics, as you said, particularly as you get over 60 in that group.
Great. Well, that's great, Joel. Thanks very much. Now we're going to move on to a very important topic,